Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, I am Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast where we share the most up-to-date education for healthcare professionals. Welcome to our podcast, Understanding the ERAS Protocol, Enhanced Recovery After Surgery. It's also known by that acronym ERAS, which is how it got its name, ERAS, and it's an approach to perioperative care that really aims to optimize patient recovery and outcomes. There are strategies that range across perioperative, intraoperative, and postoperative phases, and each phase, the goal is really to reduce complications. Joining me for this discussion is Joanna Grayson. Joanna, thank you for being here for this discussion.
Thank you very much for having me.
Yes, can you give us a little bit about your background?
Sure. So I'm a registered nurse, and I currently work in the education field. And in terms of clinical background, I've worked in everything from med-surg to elementary school.
That's a diverse range. Elementary school to the operating room. Med-surg. What about OB, peds?
I have done that as well. Yeah.
Wow. That's a very... I have not gone to that floor. That is a floor I'd like to stay off of, is OB and peds. But yes. Now I want to really start off with the ERAS protocol. As you know, where did the ERAS protocol come from? How old is it? What is it?
Sure. So as you mentioned, the ERAS protocol stands for Enhanced Recovery After Surgery. And it is a protocol or a set pathway of evidence-based clinical guidelines that clinicians can use to promote faster recovery in post-surgical patients. It is known for reducing hospital stays, surgical complications, and readmissions, which of course means reducing costs
Right.
for facilities.
What are the primary objectives within the ERAS protocol? Well, I will say, I thought I read that the ERAS protocol actually came from Denmark.
It did. It did. It came from a Danish physician, Dr. Henrik Kellett, from the University of Copenhagen, and he implemented ERAS in 1997 during a colorectal surgery. And it has expanded from there. It's used in most industrialized nations, and it's used for all different kinds of surgeries. Everything from breast reconstruction to bariatric to hepatic, gynecological, urological, rectal, and so on.
How come I have not heard of this? You say, it started in 1997, but I still in the hospital setting have not heard of the ERAS protocol. Is it not is it not popular, or is it just becoming popular?
No, it has been around. I think there have been some issues with compliance with it. And with like any protocol, clinicians have to use it consistently for it to be effective. And this, of course, falls on the shoulders of nurses because nurses are the team members who are with patients throughout the whole process, the whole surgical process. And so nurses have had some barriers to adapting ERAS.
Okay. That makes
And
sense.
so, yeah.
Absolutely. Keep going. I interrupted you.
No, that's okay. So some other history about the ERAS protocol is that when it was first introduced in the orthopedic setting, it was used for total hip arthroplasty and total knee arthroplasty surgeries because those are high volume surgeries that tend to be very costly. and that also equate to longer hospital stays. And so ERAS has seen a lot of success in the orthopedic field.
Okay. What are those primary objectives that he was trying to hit when he developed this protocol?
Sure. So what makes ERAS different from the traditional perioperative models is
Hmm.
that with ERAS, patients receive a lot of education and counseling in the pre-admission phase and in the preoperative phase. And of course, when patients receive that level of education and counseling, it empowers them. It empowers them to take care of their health. The other thing that makes ERAS different from the traditional protocol is that it uses multimodal analgesia, which we can get into in a few minutes.
Yeah.
And then it also encourages early mobilization right after surgery.
Hmm.
And the difference, how that difference from the traditional perioperative model is that the traditional perioperative model really did not educate and empower patients about their procedure. So, of course, in turn, patients had a lot of anxiety, particularly a lot of anxiety about the pain that they were going to face after surgery.
Hmm.
And so, when patients have that level of anxiety and distress going into a surgery and after a surgery, there's a higher risk for complications and slower healing. Also, the traditional perioperative model really relied heavily on opioids
Hmm.
as the main pain medication. And ERAS is a little bit different from that, which we can get into.
Hmm.
And then also, the traditional perioperative model relied on surgical tourniquets and drains, which are not used as much anymore. Research has indicated that those strategies are not very effective for most surgeries. And then, of course, the traditional perioperative model emphasized bed rest. So
Hmm.
after surgery, patients were told to stay in bed and rest. And what we know now is that bed rest leads to respiratory complications, slower wound healing, thromboembolism, blood
Hmm.
clots, those sorts of things. So, one of the main goals of ARS is to get the patient up and out of bed as soon as possible after surgery.
So, just listening to you describe all of these things, and I know we talked about nurses, playing a major role in this and this protocol, and that's probably why we don't see it adopted as much as we would like. But listening to some of the things you're saying, it makes me think physicians also would be hesitant, especially those who, wait, I can't have my drains, I can't have my tubes, I can't,
Right.
that's different. So, what are you seeing there with physicians?
So, the issue with any new protocol that's being used is that it is based in evidence-based research, which is
Hmm.
going to be newer information. Most clinicians tend to do things how they were taught in
Yeah.
school, and they tend to hold on to those practices throughout their career. And so essentially, it's harder to teach an older dog new tricks.
Right.
And so when we learn something in school and we've implemented that for X number of years in our practice, and then new research comes around and says, hey, actually, what you've been doing for 10, 15, 20 years has been found to not be as effective as this
Hmm.
other way of doing things. And then we see where clinicians kind of dig their heels in and
Yeah.
are not willing to accept the new practices.
Right.
So that's one of the barriers with ARS is that clinicians, whether it's physicians, nurses, anesthesiologists, techs, it doesn't matter. A lot of them want to hold on to the ways that they were taught, and they're slow to adopt new practices.
Which could mean why we're slow to adopt the ERAS protocol in some
Right.
areas.
It,
more readily. What I did see is, we were talking about that this was developed, I think you said 1997. So
Mhm.
I did see that so that's roughly what, 2 decades of clinical research. And
Right.
what I saw was that it showed reductions in complications, reduction in length of stay, and reduction in overall healthcare costs. So I'm curious what, other than just us not wanting to go away from what we were taught, it seems like the evidence is there.
It is. And in terms of cost, which, as we know, the healthcare system is
Mhm.
always concerned about cost of care.
Right.
And so some research has come out about how the ERAS protocol translates to saving money.
Hmm.
And so essentially, research has found that ERAS can reduce hospital stays, surgical complications, and readmissions by as much as 50%,
Wow.
which is tremendous.
Yeah, it is.
It also saves about $7,000 per patient compared to standard care.
Hmm.
And so at the University of Virginia Healthcare System, they found that they were able to save $778,000 within the first 6 months of launching
Hmm.
their ARIS protocol. They
Wow.
also found that their patients' opioid use fell by 80%.
That's huge.
Yeah, and that their patient satisfaction rate doubled.
Mm. That's huge too. Because it's
Yeah,
not
it
just
is.
about the money.
No, no. In St. Mary's Hospital in Waterbury, Connecticut, they had an increased revenue of about $750,000. And then they also studied how using the ARIS protocol impacted rates of infection, post
Mm.
surgical infections in patients.
Yeah.
And they found that surgical site infections, which are very costly to treat, that when they implemented ARIS, that they were actually able to save $28,000 per infection.
Wow.
Yeah. And that equated to $1.5 million in savings for them. So the research is there that ARIS does work
Hmm.
and it is effective, but like any protocol, it has to be used consistently. And of
Right.
course, there are those barriers that we talked about.
Right. So if we go back to the ERAS protocol itself, what are the key components and how do they contribute to the improved patient outcomes that we're seeing?
Sure. So there are 4 stages of the ARIS protocol. The first is the pre-admission stage.
Hmm.
The second is the preoperative stage. The third is the interoperative stage. And then the fourth is the postoperative or discharge stage. So during the pre-admission stage has 2 main goals. The first is to educate the patient.
Hmm.
The second is to correct any underlying conditions that the patient may have that can lead to poor post-surgical outcomes. And so during the pre-admission stage, the clinical staff will educate the patients about their condition, about the procedure. They'll offer emotional support, and they'll also explain the healthcare team's expectations of the patient, particularly while they're hospitalized after the surgery, and what that patient's role is in their own recovery process. And then diagnostic tests, imaging, comprehensive patient history can detect any underlying conditions, such as malnutrition, anemia, and those can get corrected before the surgery. If the patient smokes, then they are required to quit at least 4 weeks before their surgery. Because as we know, smoking can delay wound healing. And
Yes.
so a lot of surgeons today, if the patient is a smoker and is not willing to quit before the surgery, the surgeon will not do the surgery. Because as we know, smoking can delay wound healing and cause respiratory complications, post post-op, and so on. And surgeons today really just do not want the liability and to take chances with that. If the patient drinks alcohol, they are encouraged to stop drinking prior to the surgery because drinking alcohol can increase the risk of infection.
Mhm.
It can increase respiratory complications, which of course increase hospital stay. Patients are encouraged to exercise as much as they are able to prior to the surgery, and they are encouraged to eat a healthy diet, mostly comprised of high fats and proteins, which can help with wound healing. So, the next stage, the preoperative stage, in the past, the gold standard for patients was not to eat or drink anything past midnight the night
Yeah.
before the surgery. That has changed. And so today, patients can eat up to 6 hours before their surgical procedure.
So I can eat supper.
Yes,
I can eat
you can have
supper.
supper. You can have supper. And again, the preferred diet is high quality protein and fat
Mhm.
with you can you can certainly have carbohydrates, and there's a little bit of a debate about the role of carbo loading prior to
Yes, I
surgery.
saw that. Yes. Please
So
talk about that.
it has been found to be effective in some surgeries and not recommended for others. So for instance, in some orthopedic surgeries, they say that carbo loading is not productive. It
Mhm.
does not enhance outcomes. Whereas in some gastric surgeries, the surgeons feel that the carbo loading does help prior to that
Oh, I think
surgery.
what I read was the debate was about carbohydrate loading and its ability to maintain your metabolic stability versus
Right,
your insulin resistance. So to
right,
reduce that insulin resistance. So
right.
it's hard for me to understand if I'm looking at it that way. Why wouldn't it be beneficial in all surgeries? Um, of course, I don't understand. I'm not doing the research on that, but yes, that's an interesting debate. I don't know the answer to that.
Well, I don't either, and that's actually why there's no specific recommendation regarding carbohydrates in the ERAS protocol. It's just essentially that patients are encouraged to eat a healthy, high protein, high fat diet
Right.
prior
Which
to and
the
after
high
surgery.
protein I know helps with healing and wound
Right,
recovery. So that makes complete sense to me that you would say, "Hey, yeah, eat high protein diet."
right.
Um, Makes
Yeah,
sense.
yeah. And fats also are of benefit, and fats are good for our skin,
Mhm.
so which also helps with the wound healing. So, to your point about the insulin resistance, patients are not encouraged to fast before surgery because fasting creates a catabolic state,
Mhm.
and that can actually cause insulin resistance. Um, and so, some research studies have been done about that, and it's not encouraged. In terms of liquid, patients can have fluids up to 2 hours before they receive anesthesia. And research studies has shown that liquids are safe up to 2 hours before induction of anesthesia because they don't increase gastric content, they
Right.
don't reduce gastric fluid pH or increase complications.
Right.
Um, so multimodal analgesia, which we touched on a little bit previously, is when different medications are given via different routes to help reduce pain at different points in the pain pathway. And multimodal analgesia is a big part of the ERAS pathway. And so analgesics will be started during the pre-op phase, as will any medications needed to help combat nausea and
Mhm.
vomiting. And then in terms of hair removal prior to surgery, That's to reduce surgical site infection, and it's actually not encouraged as much anymore. If the hair can stay intact, then
Hmm.
surgeons are apt to leave the patient's hair, body hair, wherever it
Right.
occurs, in relation to the surgery, to leave that intact and to use prophylactic antibiotics or
Hmm.
a dilute betadine lavage instead of doing hair removal. Then the interoperative stage, this is where the surgical team they'll warm intravenous fluids, they'll use warming blankets, they'll also warm and humidify any of the anesthetic gases that the patient is receiving. And all of these are to promote a normal body temperature and to prevent hypothermia.
Right.
And the goals of fluid management during this stage are to maintain the normal body fluid compartment and to facilitate waste excretion, and also to help the patient be able to return to their normal oral fluid intake as soon as possible after surgery.
Yes. It all sounds really good.
Yeah, and then, if a urinary catheter is used during surgery, the ERAS protocol recommends that that catheter be removed within 24 hours after the surgery to prevent complications of urinary tract infection. And then, of course, medications to prevent blood loss, and decrease transfusion rate, and all of that are also used in the protocol. And then the last stage, the postoperative stage, the main goal of the postoperative stage is to return the patient to a baseline state of health as close to their pre-surgical state as possible. And so one of the strategies is to allow the patient to eat a regular diet as soon as they're able to tolerate food after the surgery. And again, with an emphasis being on healthy proteins, healthy fats, vitamins, minerals, probiotics, complex carbohydrates, and also for the patient to start drinking fluids, particularly water, to help prevent any blood clots. And then ice and compression, elevation therapy can be used to reduce any post-surgical swelling and pain and improve the patient's range of motion. And then the primary goal in the postoperative stage, in terms of returning the patient to optimal health, is to discharge them to home versus a rehab facility. So the main goal is to return the patient to health as much as possible so that they can go straight home and not have to go to a rehab facility.
It all makes sense. It all sounds great. It sounds like that's the care we should be giving our patients anyway when they're
Right,
going through surgery is how do I keep their infection rates down and how do I get them mobile? How do I get them eating because they need the nutrition in order to heal their wounds that we've created in surgery.
right,
We call them incisions, however we want to call them, but it's still a wound to the body. The body has to heal from.
right.
But I see nurses playing a really big role in this with the education that you're talking about, with the mobilization, with, making sure that they adhere to their pre-op plans along with their post-op plans as well. So that's that's a big role that nurses are playing. Do you see other healthcare professionals? I mean, do we see physical therapists being utilized in an ERAS protocol to help with mobilization? Do we see nutritionists being pulled in to help? Do we see that, or does it really just typically fall on the nurse?
No, and that's a great question. No, I mean it falls on the shoulders of all of the clinicians. So physical therapy, occupational therapy, respiratory therapy, pharmacists, dietitians, nurses, surgeons, and so on. So everybody has their role and everybody is included in the protocol. And sometimes One of the reasons why the protocol is not as effective as it could be is because those team members may not be communicating in the way that they should. And so, one of the ways that clinicians can help improve that is to implement real time documentation, keep their documentation up to date so that the other team members can log in, look at the patient health record, and understand where the patient is in the process. And also for the team members to just have huddles and to make a point to update each other and include each other in the communication.
And then, of course, you have the time constraints with making sure that you have your documentation done in a timely manner.
Right.
Like you were talking about earlier on, we were talking about some of the challenges of this and how it is a lot that you're putting on a nurse as well. But then, the time constraints that we have. I want to go back to when you were talked a little bit about the analgesia and how that plays a role in the ERAS protocol. And we mentioned the multimodal use of pain management. Can you talk a little bit about that and the benefits of that within the ERAS protocol?
Sure. So, the main goal of the ERAS protocol is to refrain from opioid use as much as possible, which is in direct conflict of what the old perioperative model was, which was to give opioid pain medication. With the opioid crisis today and everything that we're seeing in relation to that, clinicians are really encouraged to use other medications for pain control, such as nonsteroidal anti-inflammatories, NSAIDs, COX-2 inhibitors, gabapentinoids, nerve blocks, skeletal muscle relaxants, and low-dose ketamine. In some ERAS protocol, opioids are used in the post-op period, but as sparingly as possible. And something else that the ERAS protocol does that is very different from the previous um, perioperative model is that the previous model really relied on patients having a PCA or patient controlled analgesia pump. The ERAS protocol strongly discourages the use of that. And the reason is because that pump interferes with the patient's mobility and their ability to be independent. And that is one of ERAS's main discharge criteria is that the patient has to be independent and they have to be able to mobilize. And so that pump gets in the way of that. Um, Instead of the PCA pump, the ERAS protocol will use a controlled release oxycodone. And this has been found to actually be better tolerated than a patient controlled analgesia pump and is associated with shorter hospital stays. And then research has also shown where corticosteroids in combination with NSAIDs and pregabalin are effective at controlling pain without creating post-op wound complications. And then
The
the other
education that I wanted to ask real quick is, early education was we're going to get you to a zero. Your pain's going to be a 0 out of 10. So is there more education around you're going to have some pain when you have surgery versus no, we're going to get your pain to just be completely gone. You're not going to have to worry about it.
No, and that's an excellent question. So, in that pre-admission stage, patients are given a lot of information about pain, what type of medications they're going to receive during the procedure, after the procedure, which medications they're going to go home with, what the proper dosing is of those medications. Is the proper administration, and so on. Because the less anxiety that patients have about pain, the better their outcome. And so, of course, knowledge being power, patients need to understand And patients naturally has a high amount of fear regarding the pains that they anticipate experiencing after surgery. And that's one of the main concepts that all patients ask clinicians about is how much pain am I going to have when I get home? You know, am I going to have access to pain medication and so on? And then some patients may request their preferred pain medication. And when that happens, depending on what that preferred pain medication is, if it's something that clinicians can work with, they certainly will, but if it's something that they don't feel is in alignment with the ERAS protocol, then they will explain that to the patient and say, "Hey, look, I understand that that medication has worked for you in the past, but we're going to try something a little different for this surgery, and here's why."
Right. That's good. Were there other things you wanted to go over when I interrupted you with
Oh,
random question about pain?
yeah, no, so of course, pain causing anxiety, it used to be in the traditional perioperative model that patients would be given anxiolytics or anti-anxiety medications prior to surgery. That's not recommended in the ERAS protocol because research indicates that they actually are not effective and they don't improve discharge criteria at all. And the other thing that patients are really taught a lot about before their procedure are the non pharmacological ways that they can help control their pain, such as
Mhm,
distraction techniques like
mhm.
listening to music, reading, watching television. If they have a pet at home, playing with their pet to help decrease their anxiety, and then using ice and anything else that
Right.
helps them feel comfortable.
So looking at mobilization and nutrition, I know we talked about the nutrition and the different types of diets that they recommend, and early mobilization and how important that is as well, because that gets your stomach moving, gets your body ready to start eating. How well is that accepted? Because I've seen a lot of patients that are like, I can't get out of bed. I'm in a lot of pain. So now we're using the ERAS protocol. Our pain regimen is different. And now we're trying to get you out of bed. Um, Now we're trying to get you to eat.
So, actually, most patients prefer even if they're not hungry after
Hmm.
surgery and they're not feeling well, they like the option of being able to eat those foods that they like to eat and that they're used to eating.
Right.
And so, patients today, when they're in the hospital, they are given a menu just like you are at some hotels when you check off the menu to order your breakfast for room
Hmm.
service. Patients are given the same thing in the hospital with options that correlate with the meal plan that they're on. And so they have choices and they can check a box and say that they want toast or oatmeal or their eggs done this way or that way or whatever. And they like having those options
Yeah.
because that feels like what they would do at home. They would wake up and say, "Oh, what do I want for breakfast this morning?" Instead of someone bringing in a tray with 3 things on the tray and they've had no option to choose those things. So now they can select, hopefully, foods that they like and that sound palatable to them.
Hmm.
Also, the medical surgical staff, when they're released from post-op and they're on the med surg floor, that staff, the nurses and nursing assistants, will accommodate them as much as they can. So,
Right.
if the patient has an upset stomach and they say, and the nurse says, "Look, we really want you to try to eat," and the patient says, "Well, I don't feel like having, what I've selected for dinner," the nurse will bring crackers or make toast, peanut butter toast, things like that, that the
Right.
patient can tolerate.
I think that errors protocol, again, as I said earlier, it just makes sense as to how we should be practicing and taking care of our patients. But there are challenges to implementing something new, especially something like this. So, can you kind of walk us through those challenges? I know we've talked a little bit about some of them, but what are those challenges we're seeing in clinical practice, and how can we maybe overcome those?
Sure. So, again, and I know we touched on this earlier, that nurses are the team members that have the most contact
Hmm.
with the patient. And so the specific challenges that nurses have with the ERAS protocol is that there are not enough nurse leaders out there who really support the ERAS protocol. And so if you're a staff nurse and your superior is not encouraging to use the protocol, then you're not going to use it.
Right.
Um, there's also the challenges we talked about previously about how some team members may not communicate effectively like they should. And the
Hmm.
protocol does work that when all team members communicate, they document in a timely manner and effectively, and so on. Having a strong nurse leader who believes in the ERAS protocol is really important to not just the nursing staff, but all of the clinicians involved in ERAS, because a strong nurse leader empowers nurses and the other multidisciplinary team members, as well as patients and families. And nurses traditionally are viewed as caregivers and
Hmm.
not as empowered, autonomous leaders. And so typically, since nurses have not been thrust into a leadership role and they don't view themselves as leaders, the multidisciplinary team members don't either. And so that is a tremendous
Hmm.
barrier because then nurses don't feel like they have the power to progress their patient along the ERAS pathway. Or if they hit a stumbling block, like say a post-op patient is not ambulating as soon as they should be
Hmm.
and as soon as was anticipated prior to the surgery, then the nurse may feel a little bit stuck in terms
Hmm.
of what to do next to progress that patient. And the nurse may feel like she or he has to defer to other team members, when in reality, the ERIC pathway is constructed so that each of the interdisciplinary team members can be independent in their decision making. And so nurses have the autonomy and the power to progress the patient along the ERIC pathway, but they just don't feel like they do. And so they feel like they have to call upon the physician or somebody else to ask permission to do certain things for the patient. So that is one of the big stumbling blocks. And nurses also, they perceive the ERAS pathways being something that takes more time
Hmm.
because it is a set protocol. And so they view that as being something that takes them time to implement, that when they go into the patient's room, that they're having to spend more time with the patient
Hmm.
that they don't actually have, and so on. But what the research has shown is that that's not actually the case, that it actually does decrease the nurse's workload, and it does give the nurse more time. So if the nurse would change his or her perspective to, okay, maybe for pre-op, I have to go in and spend 15 minutes talking with the patient and the family, providing all of this education. And yet that's 15 minutes. That's a big chunk of time for a nurse, 15 minutes. And so if they look at that and say, well, that's going to be 15 minutes that I have to spend in this patient's room, but instead of viewing it that way, if they look at it as this is preemptive, because the more education I can provide, the better the outcome for the patient. And therefore, if it prevents the patient from getting an infection or having pain that's uncontrollable, those sorts of things, then it really does save time. Because an infection means I'm going to be in the room all of the time, giving IV medications, changing wound dressings, and so on. So I think a perception shift is needed for that. And
Very
then,
true.
of course, I'm sorry.
I was just said very true.
Yeah, and then, of course, in healthcare in general, but particularly in nursing, we have seen a tremendous exodus from the profession, and we have had a nursing shortage for decades. And COVID certainly did not help the situation. And so we've had a lot of nurses leave the profession. And this negatively impacts ERAS because
Hmm.
that means that facilities now are relying on temporary nurses or agency nurses or travel nurses who are not full time regular employees to help fill the nursing shortage gap. And those nurses who are not a permanent employee as a facility are going to be less likely to adopt anything that they don't view as being useful.
One of the things I
Like,
was thinking about as you've been walking through this is something that stood out to me was data and metrics. Okay. So you have things that you're going to measure. But like you mentioned earlier, what if you have a patient that doesn't eat or a patient that you can't get up on in that time that is set aside when you're supposed to be getting up? So then the question becomes, are we being tracked and measured? Is our performance as an employee of that facility, as a nurse, is it being tracked and measured by the fact that I can't get my patient to get up even though I've done everything I possibly can? That patient still has free will. I can't. um so that was a question that kind of came to my mind, and also could kind of be a barrier. And then the other thing that I was thinking of is when you're talking about the fact that we are short staffed in so many places. Number one, a lot of times contractors, they don't necessarily invest into the facility, into the team.
right,
I mean, a lot of them do, but a lot of them do not. Plus, now you have nurses who are already short staffed, already feeling the burden of all the hats that they're carrying. And now I'm saying, oh, no, you've got to add this on and you've got to add that on, rather than seeing how we can fit it into what we're already doing. Maybe it's overwhelming because now all I hear is I have to do this now.
right.
Those
Yeah.
those were two things that just kind of stood out to me while you were going through. I don't know if you want to talk a little bit about that.
Sure. And those are very pertinent observations. In terms of tracking the success of ERAS, that's where auditing comes into play.
Hmm.
And so auditing any sort of protocol is very important for the facility to do so that they can track to see if that protocol is being successful. Is it really helping patients? Is it taking a burden off of clinicians? Is it saving the facility money? And so the way that facilities can do that is that they can implement real time checklists. They can track things such as multimodal analgesia. What types of analgesics are they finding? For instance, patients who have had a hip replacement or knee replacement, what type of pain medications are they finding to be more effective in that patient population? And that means tracking data, recording the type and the length of surgical procedure and the skin prep used. And then, of course, was that skin prep effective or have they seen an increase in surgical site infections? Using daily team huddles to improve communication and to remind team members, let's be compliant with this protocol, let's follow the steps. and calculate the outcomes for our patients. Implementing real-time chart audits
Mhm.
as opposed to waiting until the patient is discharged and is at home and then reviewing the chart. It's much better to do it in real time while the patient is still there as a patient in the hospital and to collect that data. And then, of course, clinicians and administrators can compile reports. They can create daily, monthly, and annual ERAS reports and then compare month to month, year to year, the success of their ERAS protocol. The other thing that facilities are really encouraged to do in terms of ERAS is to start implementing their own randomized controlled study and gathering that information and sharing it with other facilities. So, for instance, a facility can create a randomized controlled study around the postoperative inflammatory response or pain reduction strategy that they have found to be effective. The other thing that clinicians should be aware of and can study are things like how does the ERAS protocol work in patients who have mental health disorders?
It's a
Is
good
it just
one.
as effective in those patients or is it not? What about those patients who have chronic renal failure, where now you're going to have to adjust medications to
Mhm.
account for that renal failure? Also, patients who may have chronic sleep impairment. Is ERAS productive for them? And have you have to change up the protocol to assist those types of patients? So providing ongoing support and education is really important. And then to circle back to the nursing issue, having an ERAS nurse coordinator
Mhm.
who can help keep the other nurses on track is really important, and someone who can help the facility implement training and education.
Sounds like a champion. You need an heirs champion on your
Right.
unit to
Right.
really champion the use of it to help you make sure that you're using it. And some of the data and metrics that you mentioned, it sounds like those studies be happening in some of your larger hospitals and some of those university hospitals where they do a lot of research and they have the staff and the time and the ability to do that research since they have students, coming in and out that can do research. But what about for just the smaller hospitals that we have, the data and the metrics? How can that be monitored to really look at the effectiveness of what they're doing with the ERAS protocol and to continue to improve what they're doing?
So even if it's a smaller facility and they don't have the resources that a larger facility has, they can still implement tracking. They can
Hmm.
still do real-time chart audits. They can still appoint an ERIC coordinator to educate staff and so on. They may not be able to do it to the extent as larger facilities, but every facility has the capability to track data.
What types of data would you encourage if it was limited to what they could actually track? What would you say, hey, let's start with tracking this?
So, breaking down the steps of the protocol and things such as patient satisfaction. So, that's something that, regardless of the size of the facility, every facility and healthcare system wants happy patients. So, they could implement questionnaires, pre and post interviews with patients, and those sorts of things to track um, what the patients are thinking about the care that they received and how effective they feel it is. And then, as I mentioned previously, tracking things such as the types of multimodal analgesia used,
Mhm. Mhm.
um, what type of skin prep used, those sorts of things.
So, how can the healthcare professionals stay informed about the latest research and best practices that are coming around for the ERAS protocol?
Sure. So there are several platforms. There's the ERAS Society, which is
Hmm.
a tremendous resource about everything ERAS related. And then the National Surgical Quality Improvement Program, and then the Agency for Healthcare Research and Quality Improving Surgical Care and Recovery. Then there's also the platform MD Metrics, which is a good resource. In terms of journal, any surgical journals are going to address ERAS. The American Journal of Surgery, the Journal of American College of Surgeons,
Hmm.
and then of course any surgical related professional associations. So the Association of Perioperative Registered Nurses, or AORN. Then there's the American Surgical Association and the Association of Surgical Technologists.
Very good. Do you have any advice for anybody who maybe wants to start the ERAS protocol in their facility?
I would say that one thing that they may find very helpful is to collaborate with a facility that has already been using the protocol, and to have those clinical administrators meet with the other facility and find out what they did to implement their ERAS program and what they felt the pitfalls were, so that the facility that wants to implement the program can hopefully circumvent some of those barriers. So, reaching out to other facilities that have a protocol, connecting with the ERAS Society, and then also having meetings with the surgical staff to find out what their experience with ERAS is. Have they worked in other facilities that have used the protocol?
As a good starting point. Those are really good. Well, Joanna, we are at the end of our time for this podcast. So while we wrap up, is there anything that you want to emphasize or that you didn't get to talk about that you want to make sure you get to touch on?
I don't think so. I think we covered everything.
Oh, well, thank you so much for being here.
My pleasure. Thank you for having me.
Yes. And now, what I want to emphasize that I think you've touched on all throughout this podcast is that implementing the ERAS protocol can really significantly improve patient outcomes, reduce hospital stays, and enhance overall patient satisfaction when it comes to surgical care. So, I do think that if you are not already using this in your facility, it would be worth the time to investigate it and plan to try to implement this within your facility. To our listeners, thank you for joining us, and I encourage you to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.